Welcome back, ladies and gentlemen. Let us now move on to the first plenary for the day on clinical cases and the future of multiple sclerosis diagnostic criteria. Presented by Professor Xavier Montalban, let me cordially invite the chairpersons, Dr. Champika Gunawardana and Dr. Harsha Gunasekara, to introduce the speaker.
Good morning. Welcome back to this second session. It will be a plenary lecture on clinical cases and the future of the multiple sclerosis diagnostic criteria by Professor Xavier Montalban, who has been with us a couple of times for the previous congresses physically, but this time he'll be coming to us virtually and will be presenting his lecture. Over to you, Professor Xavier Montalban.
Well, thank you very much. I hope you can hear me well. So first of all, I would like to thank very much the organizers, specifically BIM, for inviting me to be there with you. Unfortunately, this time I couldn't make it. I will be showing a few cases in which the new diagnostic criteria were very useful, and also I will review with you the 2024 McDonald criteria. Yes, go here. This is my disclaimer slide. This is case one. Let me just hide this. Just a little bit. Sorry. Okay. Can you hear me well? Can you see me well? I change a little bit this. So this is a case one. It's a 33-year-old female. She had a left optic neuritis, and in her brain MRI, as you can see here, I hope you can see my pointer, you can see only periventricular lesions. Nothing in the brainstem, nothing juxtacortical, nothing in the spinal cord. We couldn't perform a CSF tap, so this patient, which is clearly multiple sclerosis in the sense that it's a young female with an optic neuritis and typical periventricular lesions, but this patient didn't fulfill the 2017 criteria with only one topography involved. Oops. Let me see what is happening here. Let me try to fix this. I don't know what is happening. Yeah. Now, right, sorry about this. Some technical issues here. And then what we did was an MRI of the optic nerves, and then we observed this left optic nerve involvement that you can see here with some degree of enhancement. I appreciate that this is going to be a little bit difficult to pick up, but there is some enhancement here. And also the visual evoked potential was abnormal. So the patient fulfills the 2024 criteria, 2 topographies now with the optic nerve there, but not the 2017 criteria. This is one example, clear example, easy example about how important is the inclusion of the optic nerve within the diagnostic criteria. This is another case. It's a 25-year-old female with a partial myelitis. The CSF was positive. We observed oligogonal bands type 2. The OCT and the visual evoked potentials were normal. In the brain, we just saw a couple of small subcortical lesions, but nothing else. And in the spinal cord, we observed 5 clear spinal cord lesions. So again, this patient, which is typically a multiple sclerosis, a young female, partial myelitis, oligogonal bands in the CSF, this patient didn't fulfill the 2017 criteria. However, when we performed the MRI, we observe again bilateral asymptomatic lesions, and here in the inversion recovery sequence, you can see them better. These patients fulfill the 2024 criteria. Another example about including the optic nerve within the typical topographies. Another case number 3, is a 43-year-old man with numbness in his right leg. In the brain, we just saw periventricular. Here you can see them. One juxtacortical, here it is, and here perhaps as well, but this is clearer. And one spinal cord lesion just up there. No gut lesions were observed, and the CSF, we didn't perform CSF TAP. Therefore, the patient doesn't fulfill the 2017 criteria, just 3 topographies, but of course, this is very suggestive of multiple sclerosis with a partial myelitis and these lesions in the brain and the spinal cord. And a number of these lesions, they were subcortical lesions, not periventricular, not juxtacortical, not in the typical topographies. They were subcortical. But more than 6 lesions had the CVS sign, as you can see here. So fulfilling the 2024 criteria. This is another example, this time using a more sophisticated approach. And the last case I'm going to show you is this 33-year-old female with a left optic neuritis, and the optic nerve imaging was normal. In the brain, we just see periventricular lesions. In fact, one lesion here. The spinal cord was normal, and oligogonal bands were positive. This is quite an extreme case in the sense that you just have one single lesion in the brain, but fulfills the 2024 criteria because that periventricular lesion has the PRL sign. So this is one extreme example, but of course you would agree with me that a young female with a left optic neuritis, this periventricular lesion, probably an oligogonal bands, this patient has multiple sclerosis. Okay, so why and how were the 2017 McDonald diagnostic criteria revised? We at the time, in 2020, in fact, we considered that the evidence published up to that date in relation to the new diagnostic markers was so huge that we wanted to review the whole literature, and we took advantage of the major advances in MRI, CSF biomarkers, and clinical understanding to review the criteria. The convening body was the International Advisory Committee on Clinical Trials in Multiple Sclerosis, which is sponsored by the SLCTRIMS and the National MS Society, and has been responsible for the production of all previous versions of the McDonald criteria. And one important thing is that we now know much better the mechanisms of disease in multiple sclerosis, and many of them we can identify them in vivo by using MRI, by using biological biomarkers, OCT, and visual above potential. And we took advantage of all these facts. So why are the MS diagnostic criteria important? You have seen this slide previously, but I have to insist that the diagnostic criteria, they do have a clear impact on the patient-doctor dialogue, and the situation of RIS is a clear example. On treatment decisions as well, of course, on clinical trials design, and also in the prognosis of multiple sclerosis. As you know, when we have an early and a great diagnosis, we typically start treatment earlier, and this has a beneficial long-term effect. And let me just show you one example coming from our center, published a few years ago. We we split our CIS patients into different cohorts, according to the different epochs, using different diagnostic criteria, as you can see here. And we observed that from Posser to McDonald 2017, there was a 77% reduction in the median time from first symptom to MS diagnosis, and an 82% reduction in the median time from CIS to treatment onset. And as a consequence of this, and perhaps due to other factors as well, the prognosis of MS is now better. And here you have the probability for reaching an EDSS of 3 or higher at the age of 40. And it decreased from 0.86 to 0.20, which is quite an impressive difference. And this finished, our study finished in 2020. Now we are in 2026. Probably the difference is even bigger. This is the diagnostic criteria evolution over time. As you know, in 2001, MRI was formally integrated into the first McDonald diagnostic criteria. However, if you read the Posters paper well, you realize that he already mentioned the use of NMR at that time for the diagnosis of multiple sclerosis. In 2024, we have integrated a number of factors. We have added fifth topography, the optic nerve. We have incorporated the kappa-free light change, PRLs, and CBS into the diagnostic criteria. These are the different diagnostic criteria and the 4 classical statements to make the diagnosis of multiple sclerosis. And the 2024 challenged 3 out of these 4 statements, and I will show you how. If you read the Thompson paper in relation to the McDonald diagnostic criteria 2017, we stress that this criteria should only be applied in those patients who present with a typical CIS or typical symptoms consistent with CNS inflammatory demyelinating disease. And this is not necessary anymore. This is the diagnostic algorithm for patients with RIS here or other presentations with symptoms not completely typical of multiple sclerosis. This is the friendly version that I wrote or I draw. And when you have a patient with a RIS or patient with other symptoms, if I go back here, you have a number of them, and they are quite frequent in our clinical practice. You have a patient who has no atypical, prototypical optic neuritis or myelitis, but this sort of symptoms. And then if the patient has a dissemination in space, which means 2 out of the now 5 topographies, and also have CSF positivity or CBS positivity or DIT, the patient fulfills the criteria for multiple sclerosis. And this is a big step forward. Remember what we mean by CSF positivity. Is when you find type 2 or type 3 oligogonal bands in the CSF. And now in the new diagnostic criteria, a kappa-free light change index of 6.1 or higher is enough to make the diagnosis of multiple sclerosis with a positive CSF. Remember that the kappa-free light change is faster, is easier, is cheaper. The CBS positivity, the CBS is the central vein sign that you can see here using susceptibility images. It's like you can see the typical vein reflecting the pathology of the perivenular lymphocytic infiltration. And you can demonstrate CBS positivity when you have 6 or more lesions with CBS, or if you have less than 10 white matter lesions, the number of CBS positive lesions should outnumber the CBS negative lesions. And also the dissemination time is still the same, very old definition, new T2 on a follow-up MRI, or the presence of gut-enhancing and non-enhancing lesions at any time in the same scan. So as you see, considering some of the patients with RIS having multiple sclerosis, we are moving forward more towards a more biological diagnosis. And this is happening in other areas of neurology, specifically in Alzheimer's, where you can have Alzheimer's disease because your biomarkers, your PET biomarkers, your biological biomarkers in CSF or in blood now are typical of Alzheimer's, but you don't require to have symptoms. You don't require to have dementia. So what about dissemination in time? Is that needed? Not anymore. You have a number of alternatives for dissemination in time. And here you have that. This is a paper published by Agustin Papola in Nature Review Neurology. And here you have a summary of how can you deal with the absence of dissemination in time. This is coming mainly from these papers published by Eugenia Rambide years ago, indicating that the presence of dissemination of typical lesions fulfilling dissemination space, or even not fulfilling the dissemination in a space, but being typical of multiple sclerosis, has a ratio of developing multiple sclerosis clinical MS was very high. And then we were able to study all the CIS trials. So thank you very much to these companies who provided all the data. And here you see that 3,000 CIS patients coming from these clinical trials in a very short period of time, 2.6 years. 84% of patients had dissemination in time, clinical or MRI dissemination in time. So the meaning here is when you have typical lesions in the typical topographies, this is going to be MS, and you don't need dissemination in time. As well, in the 2024 criteria, we observed that in some of the papers that we published, this is one by Wallace Brownlee, that when you have 4 regions involved, there is a high specificity for MS, so you don't need anything else. And I think this is also very important. So apart from these 4 typical topographies, now we have incorporated the optic nerve. There is a companion paper in the same issue in Lancet Neurology, where you can see the review, all the evidence indicating why we incorporated the involvement of the optic nerve in the diagnostic criteria. Let me just highlight the work by Anca Vidal from our lab, with a couple of papers in neurology indicating that the addition of the optic nerve as a 5th topography by using MRI, OCT, or visual potentials it's perfectly fine. These are now the 5 typical topographies: preventricular, juxtacortical, preventricular, optic nerve, and spinal cord. And again, I think I repeat this always 2 or 3 times, but we require typical lesions in typical topographies to avoid misdiagnosis. This is the other algorithm, the other diagnostic algorithm for patients with a typical attack, typical CIS, or objective progression for more than 12 months. And here you have the more friendly version. Again, if you have 2 lesions in 1 lesion in 2 topographies or more, and then you have the CSF positivity, CVS, or DIT, all lesions are present in 4 or 5, that is going to be MS. But now with this version, this iteration of the McDonald criteria, even patients with 1 topography, they may be diagnosed with multiple sclerosis if they have PRL, CSF positivity, and PRL, CSF positivity, and CVS, DIT, and CVS positivity. You can see all the combination here. Let me just highlight the PRL positivity to indicate that the paramagnetic rim lesion, which is the iron deposition in the border of a chronic active lesion typically, is very specific. It's not pathognomonic, but almost pathognomonic of multiple sclerosis. If you see 1 of these PRL lesions in your patient, this is going to be MS. Sorry. What else? Well, in theory, diagnosis of MS can be made by clinical assessment alone. This is not going to be like that anymore. We ask for corroboration by using paraclinical tests, specifically MRI. And I think in 2025 or 2026, make the diagnosis of multiple sclerosis without an MRI showing the typical lesions is a little bit risky. Again, the MRI is the main piece in here. Then you may wonder, well, what about the accessibility, the access to MRI in a number of countries globally? Well, this is a survey that the MSIF performed and was presented at the ECTRIMS 2025 and is now being evaluated for publication. And it was a little bit surprising in the sense that most of the countries, even those with low and lower middle income, they had access to the MRI in a reasonable time. I don't know if this is completely true or not, but this is what that survey indicated. What about the exclusion of other diseases? That remains. No way. You have to rule out other conditions, although in expert hands, this is not very difficult, I guess. I think I'll probably show you some of the cases with neurosarcoidosis that were confounded with multiple sclerosis, but in expert hands, I think we can be quite good in making the diagnosis. Another question is, well, a patient fulfilling 2017 criteria may not fulfill the 2024. I would say that no for relapsing MS, but in primary progressive MS, there is a theoretical way of this happening. So this is the 2017 criteria. This is the 2024 criteria. Imagine a patient with a progressive disease for more than 1 year, and then 2 spinal cord lesions and 1 preventricular lesion. You don't have any doubt that this is going to be primary progressive MS. However, this patient would fulfill the 2017 criteria and not the 2024 criteria. We have reviewed our cases and we haven't found this yet, but it's possible that in the future some of the PPMS would be in this situation. Well, another question is, will the 2024 revision will increase the number of and the speed of MS diagnosis? And the answer is yes, we believe so. This is a theoretical scenario. Here you have the 2017 cases fulfilling the diagnostic criteria, and then you should add here the RIS cases that would fulfill the criteria. Then adding the optic nerve, you would increase the number of cases with the diagnosis. Using kappa-free light change with also will also increase the number, and in few specific MS centers, the CBS and PRL will increase the number of cases. So this is in theory, but also take into account that we have now additional features in all the patients, and older means older than 50 years. And patients with vascular risk factors. So that was not very clear what was going to happen. And we reviewed that, and this was presented at the ECTRIMS as an oral communication. And here, what we observed, reviewing our cases, is that there was a 42% relative percentage increase in the number of cases diagnosed with multiple sclerosis. And also, we, as I mentioned before, we found no patients fulfilling the 2017 and without also meeting the 2024 revision. And importantly, the McDonald's 2024 anticipated the diagnosis by 6 months, which is not trivial. If you read the paper by Alvaro Cobo indicating how important it is to start treatment within the first 6 months after the first symptom. So this is a key question, mainly for our American colleagues. Will the 2024 revision increase the risk of misdiagnosis? We have already worked a little bit on that. I would say that not in our hands, but we are a very specialized MS center. I don't know in other countries where the MRI is not well described, neurologists don't have too much experience. But in theory, this is not going to be the case for a number of reasons. One is that we increase the specificity by adding the need of clinical evidence, specifically MRI, to make the diagnosis. Also, the presence of PRLs and the CBS are very specific of multiple sclerosis. I give you that this is not going to be possible in a number of hospitals around the world, but if you found them, this is going to be very specific. We also ask for the determination of antibodies in children younger than 12 years. And as I said, in patients with older than 50 years or with vascular risk factors, we ask for additional features, as you can see here, spinal cord lesion, CSF positivity, or CBS. So these are the proposed revisions. As a summary of that, I'm not going to read that, but I think, well, perhaps let me just highlight that we are going to use more almost the same criteria for PPMS and relapsing MS diagnosis, and I think this is also important. So in my view, the title you gave me is the future as well. So I think this is going to happen in the future, that any option, so one typical CIS, progression, typical RIS, or other presentations with symptoms not specific to MS, if they have at least one typical lesion in a typical topography and not red flags, of course, or other symptoms suggestive of other conditions, if they have just one topography, one lesion in one topography, and also one of these factors, CSF positivity, CVS positivity, PRLs, or DIT, this is going to be multiple sclerosis. And this is my last slide. This is the family photo with people involved in that. I think it was a great success to publish a paper in Lancet Neurology, but also with 3 companion papers, one on MRI, one on a visual pathway, and the other one on CSF. And with this, I thank you very much again for your attention.
Thank you very much, Prof. Xavier. It's an excellent talk, and I think we can entertain a couple of questions from the audience.
Good morning, my dear Xavier. This is Peter Hartung. Excellent talk as always. May I just ask you a question? How is your view on the impact of the new diagnostic criteria on the diagnosis and differential diagnosis of NMOSD and MOGAD?
Thank you very much, Peter. I can see you very well, and also Leticia behind you. So I hope you are enjoying the city and the Congress. Again, it's a little bit tricky, that question, Peter, as you know, because we say in the MS diagnostic criteria you should rule out other conditions. If you go to the NMOSD MOGAD diagnostic criteria, mainly NMOSD, you should rule out multiple sclerosis. It's a little bit tricky, but again, if you have any suspicion that the patient may have NMOSD or MOGAD, you should go for the antibodies, and there are a number of differentials in the MRI images as well, and I think with that, and clinically there may be some differences as well. So I think in expert hands, in most cases there are no doubts, mainly if you have the right technical tests. I have to say as well that sometimes we have difficulties, and in very few cases we have the feeling that they do have both diseases, MOGAD and MS. Sometimes are NMOSD and also multiple sclerosis, but this happens in very few cases.
Thank you very much. Please have a cup of very strong coffee and enjoy the weekend. See ya.
Thank you.
Okay, then thank you very much, Professor Montalban, and thank you. And I think we'll move on to the next part of the session. Thank you.